Good afternoon. I'm Commander Ibad Khan, and I'm representing the Clinician Outreach and Communication Activity COCA with the Emergency Risk Communication Branch at the Centers for Disease Control and Prevention. I would like to welcome you to today's COCA Call, Underlying Medical Conditions in Severe COVID-19, Evidence-Based Information for Healthcare Providers. All participants joining us today are in listen-only mode. Closed captioning is available for today's webinar. A transcript and closed caption video will be posted to the COCA Call webpage at emergency.cdc.gov/COCA shortly after today's live session. Again, that link is emergency.cdc.gov/COCA. Free continuing education is offered for this webinar. Instructions on how to earn continuing education will be provided at the end of this call. In compliance with continuing education requirements, CDC, our planners, our presenters, and their spouses, partners wish to disclose they have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. Planners have reviewed content to ensure there is no bias. This presentation will not include any discussion of the unlabeled use of a product or a product under investigational use. CDC did not accept commercial support for this continuing education activity. At the conclusion of today's session, participants will be able to accomplish the following: discuss methods used to review evidence of association between underlying conditions and severe COVID-19, including 2 large cohort studies. Describe the risk associated with specific underlying conditions from the 2 cohort studies and studies using other methods. And list resources available for healthcare providers caring for patients with underlying medical conditions. After the COCA call, there will be a Q&A session. You may submit questions at any time during today's presentation. To ask a question using Zoom, click the Q&A button at the bottom of your screen, then type your question in the Q&A box. Please note we receive many more questions that we can answer during our webinars. If you're a patient, please refer your questions to your healthcare provider. If you're a member of the media, please contact CDC Media Relations at 404-639-3286 or send an email to media@cdc.gov. Now it is my pleasure to welcome our presenters for today's COCA call. We are pleased to have with us Dr. Sapna Bamra Morris. Dr. Morris is the Clinical Disease Team Lead for the Health Systems and Worker Safety Task Force for CDC's COVID-19 response. Our second presenter is Dr. Kanta Sarkar. Dr. Sarkar is an epidemiologist on the Clinical Disease Team for CDC's COVID-19 response. And our third presenter is Dr. John Brooks. Dr. Brooks is the Chief Medical Officer for CDC's COVID-19 response. It is my pleasure now to turn it over to Dr. Morris. Dr. Morris, please proceed.
Thank you very much, Commander Ibad. If you could, Commander Khan, sorry, if you could go to the next slide, please. We at CDC are very interested and want to serve as a resource for healthcare providers on understanding risk factors for severe COVID-19 based on our patients' underlying medical conditions. We hope that the information we provide will increase the knowledge of risk, which would then in turn help providers make informed decisions about patient care and how best to advise patients in preventing infection from SARS-CoV-2 and development of COVID-19. We have developed web pages that serve as living documents that we are attempting to update on a more regular basis to share the information that we learn. We released a clinician page that's dedicated for healthcare providers to review the evidence that we have looked at and described in order to learn a bit about the risk associated with underlying medical conditions. This clinician page is divided into 4 sections. There's background information and actions clinicians can take to keep patients safe, a review of 2 large cohort studies of conditions associated with severe COVID-19 outcomes, a summary of the literature on conditions that are associated with severe COVID-19, and additional resources clinicians can use to learn more about COVID-19 diagnosis, treatment, and prevention. Today, during this COCA call, we would like to share some background information, review the methods, how we review the literature and create the clinician page, show the categorizing of the evidence, share with you the findings of those 2 large cohort studies, and review actions healthcare providers can take, in addition to providing resources that can help to inform your decision-making. With that, I'd like to start with the background, and then we'll turn it over to Dr. Sarkar for the methods. Next slide, please. Next slide. This graph depicts the trends in case counts and rates since January 1st, 2020. The orange line here shows the 7-day incidence rate, the blue bars, the case counts, and the red line, the daily average number of cases. These data are reported in the US as of May 24th, 2021. And as you can see, or as you may know, we are approaching approximately 33 million cases in the US, with a 7-day moving average of about 23,000 cases. The incidence rates peaked in January and now are declining. Next slide, please. This graph depicts the trends in death counts and rates since January 1st, 2020. Again, the orange line here represents the 7-day death rate. The blue bars, the number of deaths. The red line, the daily average number of deaths. And again, as you can see in the box here, the deaths reported in the US as of May 24th, 2021 are over 587,000, with a 7-day moving average of approximately 500 deaths per day. The death rates peaked in April 2020, and then again, and with a higher peak in January of 2021, and are now declining. Although these graphs do show us that cases and deaths are declining, we do need to stay vigilant, keep recommending vaccination and other prevention measures, especially among those who are at risk for severe COVID-19 disease. Next slide, please. This graph depicts the US COVID-19 cases reported March 2020 through May 2021 by age. Most cases reported were among patients aged 18 to 24. The fewest cases were reported among those 0 to 5 years of age. We highlight this because despite the fact that the largest number of cases fall in the young adult category, we know that the strongest risk factor for severe COVID-19 outcomes is age. Next slide, please. This slide then reports the COVID-19 deaths reported to CDC by age group. And this is again from March 2020 to May 2021. Again, most cases occurred among younger adults, as we showed in the last graph, but most deaths occur among the elderly. Approximately 54 million people aged 65 years or older reside in the US, and this age group accounts for more than 80% of US COVID-19 related deaths. So again, we just want to emphasize that age is by far the strongest predictor of COVID-19 death. Next slide, please. This table reflects the risk of severe COVID-19 outcome, hospitalization or death, associated with age. As you can see here, the age groups are compared to our referent group, which is ages 5 to 17 years. Older adults are at increased risk for hospitalization and other severe COVID-19 outcomes, including ICU admission. This table shows us then, with increasing age, the risk of severe COVID-19 outcome increases exponentially. Physicians who care for older patients should be strongly urging their patients to receive vaccination, in part because their risk of hospitalization and death is so high relative to younger adults. Physicians should consider which elderly patients are immunocompromised and remind them to take continuing precautions even after vaccination. Next slide, please. Age, as we mentioned, is clearly the strongest predictor of severe COVID-19, but it does not affect all populations equally. Members of certain racial and ethnic groups, when compared to non-Hispanic white persons, are dying from COVID-19 at younger ages. This graph shows us the distribution of COVID deaths. The red bars show you the distribution of deaths. The blue bars, the population distribution by race. In these data, the age is standardized so that racial and ethnic groups can be compared. Thus, this graph shows us what disparities would look like assuming the same age distribution as the 2000 standard population. COVID-19 deaths disproportionately affect Hispanic, non-Hispanic, Black, and American Indian and Alaskan Native populations. We're still learning how race and ethnicity, social determinants of health, including neighborhood and physical environment, housing status, occupation, education level, food security, access to healthcare, and economic stability can influence the risk for infection and severe COVID-19 outcome. But physicians who care for patients in these racial and ethnic groups should work to ensure that their patients are both vaccinated, understand this risk, and take proper prevention measures. Next slide, please. I'll turn it over now to Dr. Sarkar to talk about the methods.
Thank you. To learn more about underlying medical conditions that increase the risk for severe COVID-19 outcome, we initiated reviews of the scientific literature. These literature reviews allowed us to identify new associations and update knowledge on known associations as information becomes available. I'm going to go a bit into the methods we use for these reviews before talking about the underlying medical conditions on our website. But first, why did we do these literature reviews? The summary of information reflects current evidence regarding underlying medical conditions and is intended to help healthcare providers to make informed decisions about patient care and to increase the awareness of risk among their patients. Next slide. So if you haven't been to this page already, this is a screenshot of our evidence page. When we talk about underlying medical conditions, we predominantly mean conditions that are, conditions that are pre-existing. We predominantly mean that they are chronic conditions. We do include one risk factor, and that is smoking. Early in the pandemic, much of the emerging evidence focused on describing COVID-19 cases who were hospitalized and who had died. Many prevalent conditions, such as obesity and diabetes, were some of the first to be identified. An initial review of the literature was completed June 2020 by CDC subject matter experts and was last updated between November 2020 and early 2021, depending on the underlying condition, and is listed on the page. The newest addition to this page was evidence of having an underlying condition and being pregnant or having a recent pregnancy. This was added in May. The amount of literature on COVID-19 and underlying medical conditions continues to increase. To understand what this all means and to be informative, we have updated our review process. Our current literature review process begins with a CDC subject matter expert for a respective underlying medical condition, a librarian, and a literature review subject matter expert working together to create search terms. Then they develop and refine inclusion and exclusion criteria. Manuscript titles and abstracts are then screened for full text and full text are reviewed. Then data is extracted and evaluated for the risk of bias. This information is aggregated and evaluated for strength and direction of body of evidence. When we talk about evidence, we include findings from CDC investigations, published reports, scientific articles in press, unreviewed preprints, and internal data. Next slide. So what are we looking for? We identify studies that looked at patients who had COVID-19 and the presence of an underlying medical condition, ideally compared to a COVID-19 patient who did not have the underlying medical condition. In these studies, we also look for other factors, such as demographic characteristics, including age, sex, and race. We also like studies that account for socioeconomic status and account for known underlying medical conditions. We define severe outcomes as hospitalizations, intensive care unit, ICU admissions, invasive mechanical ventilation, or death. Next slide. So we've organized our list to align with the hierarchy of evidence. Next slide. This is a screenshot of how our literature is listed on our webpage. On our scientific brief webpage, we present evidence of certain underlying conditions in categories that follow the hierarchy of evidence. The hierarchy of evidence is a ranking of studies based on methods used. Although some underlying medical conditions, such as obesity and heart disease, have a large body of evidence that consistently demonstrates a strong association with severe outcomes, other underlying medical conditions are harder to detect. For example, literature on rare conditions or less common conditions where it took time to establish enough sample size to do more than a case studies or case report may not have cohort studies. Presenting these data in this way hopefully allows us to provide additional insight, and the categorization allows clinicians to easily access the quality of evidence. Within each category, the conditions are listed alphabetically. In addition, because our knowledge of underlying medical conditions is based on the ever-evolving literature, this list may not be reflective of all underlying medical conditions. Next slide. So this list of underlying medical conditions was categorized into 4 groups, primarily based on the study methods used in that publication. The groups include meta-analysis or systematic review, observational studies, for example, case control, cross-sectional, or cohort, case series or case reports, and studies that have mixed evidence. These are consistent with the hierarchy of evidence. And I'll explain each one as I go along. Next slide. The first category is those studies or those conditions supported by meta-analysis or systematic review. This category has our strongest evidence, meaning that there is consistent literature showing an association with severe outcomes. The blue star indicates literature on pregnancy or having a recent pregnancy and having an underlying medical condition or that respective underlying medical condition. The list is alphabetical, in alphabetical order, and includes cancer, cerebrovascular disease, chronic kidney disease, COPD, diabetes mellitus, heart condition, obesity, pregnancy and recent pregnancy, smoking, current and former. This category has medical conditions where the association with severe outcomes are well established, but it also has one risk factor, and that is smoking. As you can see, some conditions are listed in larger groupings. For example, heart disease includes coronary artery disease, heart failure, and cardiomyopathies, among others. These groupings may reflect how conditions were defined in some early studies that use large grouping algorithms such as the Carlson-Deo comorbidity. And we'll go back to that one framework later on. Next slide. In this category, there is a growing body of literature to support the underlying medical condition being associated with severe outcome. At the time of the review, no meta-analysis or systematic review had been identified. However, there was evidence from cohort, case control, or cross-sectional studies. This list includes certain underlying conditions in children, Down syndrome, HIV, neurologic conditions, overweight, other lung diseases, sickle cell disease, solid organ or blood stem cells transplantation, substance use disorders, use of corticosteroids or other immunosuppressive medications. Again, we see common conditions such as being overweight and some not so common conditions such as Down syndrome. There are also groups of conditions in this category. For example, certain underlying medical conditions in children, which includes many, many underlying medical conditions in children, and those risks of underlying conditions might vary. Next slide. This condition, in this list, case series and case report, these conditions have been studied by one or more case series or case reports. If more complex study designs are used to study these conditions, the sample size was small. At the time of the review, no systematic review or meta-analysis was conducted on these conditions. This list includes conditions that are less common. However, we do expect that the body of evidence to support the association of less common conditions with severe COVID-19 outcomes will grow with time, and there will be a broader range of studies conducted. Cystic fibrosis and thalassemia currently are on the list. Next slide. In this category, it is hard to reach a conclusion about the association of these underlying medical conditions with severe COVID-19 outcomes. While some studies of a specific underlying medical condition found an association, others did not. One reason may be that the definition of an underlying medical condition, for example, liver disease, is too broad and needs to be better defined into subcategories. In addition, there are 4 outcomes that serve that define severity: hospitalizations, intensive care unit admissions, invasive mechanical ventilation, and death. The underlying medical condition may be associated, for example, with invasive mechanical ventilation, but not with death. As mentioned previously, we are looking at the literature for new information. For this group of conditions, we are currently reviewing the literature to better understand what is known, which means it may be in different levels of severity or subgroups. As the association becomes clearer, these conditions will be redefined into those subgroups. These conditions include asthma, hypertension, immune deficiencies, and liver disease. Next slide. So I'm not going to go and to present all the evidence that we have to support each of the underlying medical conditions that I just mentioned. Instead, I will present findings from 2 large cohort studies that are featured on our website. These are used to highlight some common themes that we see in the literature, such as 1, age is the strongest risk factor for severe outcome. 2, severity plays a role. And 3, having more than one underlying condition may increase your risk for more severe outcomes. But first, let me describe the studies. Next slide. So the first study, which we will refer to as Rosenthal et al., was conducted in the United States and used data from the Premier Healthcare Database, which is a large geographically dispersed hospital-based severe service level all-payer database, which represents approximately 20% of all inpatient admissions in the United States. The study includes over 64,000 inpatient and hospital-based outpatients visits with laboratory-confirmed COVID-19 diagnosis between April and May 2020. This study was designed to examine risk factors associated with in-hospital mortality, and the analysis was conducted using multivariate logistic regression among adults, adjusting for demographic characteristics, visit characteristics, comorbidities, and hospital characteristics, among other factors. The outcomes they looked at was the in-hospital mortality. Next slide. So the second study, which we will refer to as Williamson et al., was conducted in the United Kingdom and uses data from OpenSafely, a health analytic platform that covers 40% of all patients in England, that is over 14 million adults. This study linked primary care records to death data to examine factors related to COVID-19 associated death. Over 10,000 COVID-related deaths from February through May 2020 were included in this study. The analysis was conducted using multivariate cost proportional hazards model adjusted for age, sex, body mass index, smoking, an indicator of socioeconomic status, and many underlying medical conditions. This study describes the risk of COVID-19 related death by severity of some underlying medical conditions. Next slide. So here are some of the results from Rosenthal et al. This study used Carlson-Deyo comorbidities, which groups mostly chronic conditions into larger categories. For example, any malignant neoplasms. These groups can then be assigned a weight, which forms the Carlson-Deyo comorbidity index. This index is associated with long-term survival. The adjusted odds ratios are listed on the right. It is in the order from smallest adjusted odds ratio to largest adjusted odds ratio. As you can see, they are close in the strength of association, ranging between 1.1 and 1.57. History of myocardial infarction and metastatic solid tumors have the highest odds ratios. When comparing these odds ratios to age, they are relatively small. Not shown on this slide is the adjusted odds ratio of age, which ranges from 2.12 in those 35 to 49 years old and 16.2 in those over the age of 40, compared to those 18 to 34 years old. One note about hyperlipidemia that is also related to hypertension. These are some common conditions, actually the two most common underlying conditions in the United States. Without information on severity or medication use, it might be difficult to describe the association. Studies report a wide range of association from adjusted risk ratios above and below 1. Some studies have identified collider bias as a reason why relationships are not as clear. Next slide. So Williamson et al. Looked at severe underlying medical conditions, but defined conditions differently from Rosenthal et al. Williamson et al. Used cutoffs based on severity. Here are two examples, and there are a few more in the paper. Patients with diabetes are categorized into three categories: those with a hemoglobin A1C lower than 7.5%, and a hemoglobin A1C greater or equal to 7.5%, and those with no recent measurement of A1C. Excuse me, patients with diabetes with a higher hemoglobin A1C have a higher adjusted hazard ratio when compared to those not having diabetes. Similarly, non-hematologic cancers were stratified by year since diagnosis. This may be an indicator of several possible factors, including tumor size, recent surgery, or immunosuppressant therapies. This strata includes diagnosed less than 1 year ago, diagnosed between 1 and 4.9 years ago, and diagnosed over 5 years ago. As you can see, those who had the most recently been diagnosed had the highest adjusted hazard ratio, and those diagnosed over 5 years had no significant, non-significant adjusted hazard ratio. Next slide. The last example from Williamson et al. We looked at reduced kidney function. Here is a hazard ratios for reduced kidney fat function by those with a eGFR between 30 and 60, and those with an eGFR less than 30. As you can see, those between less than 30 have a higher adjusted hazard ratio compared to those between 30 and 60. Next slide. So lastly, the number of underlying medical conditions may be an indicator of severity. Here is one example. Rosenthal et al. Used Carlson-Deyo comorbidity index score to indicate as one indicator of multiple morbid conditions. Those who died had an average index score of 3.1 compared to those who survived, which was 1.1. This score accounts for the number of underlying medical conditions, and for some conditions, the severity of the condition. They also looked at the frequency of Carlson comorbidities. Of those who had zero comorbidities, 97.2% survived, and only 2.8% died, compared to 5 or more comorbid conditions, where 66.6% survived and 33.4% died. In summary, underlying conditions are associated with severe COVID-19 outcomes. Factors such as severity of underlying medical conditions and the number of underlying medical conditions are also important factors. It is important to note that age still remains one of the strongest risk factors. So that is the summary of what we know of underlying conditions as a whole. I will turn it over now to Dr. Brooks so we can talk about what clinicians can do.
Kanta, there we go. Kanta, thank you so much. And Sapna as well for that really nice presentation. You know, I'm thinking about when we gave this a talk, a COCA Call, in fact, about this same topic about a year ago, and how really far we've come in our understanding in just a year in this topic area of underlying conditions and their effect on people who've got COVID. So let's go forward to the next slide, please. And what I want to do today is just go over, for those of you on the line who work in a clinical capacity, just to share with you some of our thoughts about what we can do as clinicians to help our patients minimize their risk of bad outcome if they get COVID-19. And again, I'm just going to reiterate, probably the most important thing we can do is get them vaccinated. This is our healthcare provider landing page, which is where, if you are a clinician and you want the detailed information that was described in the last 30 or 40 minutes before me. You can find it here. There's a lot of detail on the methods, the studies looked at, how we as an agency sort of do the reviews, rank things, and I hope that for those of you who are looking for a deeper dive, that will provide some useful information for you. Next slide, please. This is, I should mention that healthcare providers are some of the most influential people in the lives of patients, including me. I listen very closely to my own healthcare provider, but particularly with regard to COVID-19. And your advice can really change somebody's life and save it. It's important for us all to educate our patients about their risk for severe COVID-19 infection. And a really quick and effective way to do it in a busy practice, or if you don't have a lot of time, is to recommend this webpage to your patients. This is the companion webpage that goes with the one we just showed before for healthcare providers. And this is intended for the general consumer to help them better understand the risk associated with underlying medical conditions. And this page is updated in sync with the healthcare provider page with new evidence as it becomes available. If you look up in the top left corner under the title, People with Certain Medical Conditions, you can see the date, and it was last updated May the 13th. Next slide, please. So these are three key areas that I wanted to talk about where we can encourage patients in different ways to do things to protect themselves. So in addition to educating patients about their individual risk, there are a lot of actions we as providers can undertake to help keep patients safe. And we're including here several strategies described on our webpage. These are some that we think are particularly or exceptionally effective, but of course it's not a complete list, and I'm sure we'll be learning more as time passes. So of course, our very first recommendation, you're going to hear this a lot from us these days because we have this tremendous intervention we can offer, vaccination. And we really need to work together to educate and encourage everyone to be fully vaccinated against COVID-19, and to do it as soon as it's possible when the vaccine is available to them. And at this time in the United States, we now know that over 90% of Americans live within 5 miles of a drugstore, a pharmacy, or another outlet where they can get vaccinated. Vaccination is our best defense against this virus, and vaccination is safe and effective for most individuals. And I want to make an important point here is that we have evidence that it works in people with underlying medical conditions, with a few exceptions that we'll talk about in a moment. So consider your patient population. Make certain to reach those who are reluctant to be vaccinated in creative ways that are acceptable to them. So we found in our experience here that may include things such as working collaboratively with local leaders, with trusted voices in a particular community, with faith-based organizations and other influencers, and possibly also having patients share their own experience with vaccination within their social circle. So to me at least, sometimes there's nothing more powerful than my friend recommending it to me rather, and telling me it was a good thing to do. I also want to point out that it's surprising, perhaps to some, it was to me, that convenience makes a big difference. And the more that we can make accessing vaccination acceptable and convenient at times and locations where people are, the better. I'm really thinking here in particular about folks who can't get away from their regular 9-to-5 job. So an on-site vaccination program if you're a large employer, or having after-hour access, or giving people time off to get vaccinated. Are some creative ways that you can really expand the impact of vaccination. Okay, second recommendation here is to encourage patients to adhere to their treatment regimens. And I don't mean treatment for COVID, I mean the treatment for their underlying medical condition. I'm sure this makes perfect sense. But we've just been through a year where people were, for a large part of that time, hunkering down, limiting their travel and exposure. And one of the things people really limited a lot was going to the doctor. It was perceived early on as a place where people could be infected. We have made the healthcare setting much safer, and I feel very confident that our healthcare setting is a very safe place for persons to go, particularly those with these underlying medical conditions that not only may put them at greater risk for severe disease, but importantly here, need to be paid attention to. Some people have set aside visits for various conditions and suffered from that because they weren't maintaining their regular care, even with the accessibility and availability of telework. And that's really critical to maintain. And I think, as you may have seen in the slides that Kanta in particular showed earlier, we've seen that the more severe the underlying medical condition and the greater number of underlying medical conditions steps up that risk for a poor outcome from COVID-19. So it's really important in particular to help manage those persons with multiple comorbidities, to keep those as best under control as possible. Okay, moving on, third one, encourage patients to keep their regularly scheduled medical appointments for routine care. That sort of fits in with what I was speaking about before, but if you have a person who is still hesitant to come into clinic, and there are certainly plenty of people out there, and we have to understand that and accept it. But there are things that we can do to work around that. Not just telehealth, because of course not everybody has access to a computer, and particularly in rural areas, broadband is limited. But you can do car-side visits. I have a friend of mine, a very creative, good friend of mine, is a dermatologist who has a whole system for doing dermatologic exams, including biopsies, in the parking lot car-side. You can do telephone check-ins as well. And some people, if they have a smartphone, may have access to FaceTime. And of course, this is a circumstance where if patients miss their regularly scheduled visits, follow-up is very important. Let them know you care about them, you're following up with them. Those of you who are engaged in this work know how important that reach out and touch can be to engaging the person and helping make sure they're safe and arranging the next appointment to bring them in. Okay, let's go to the next slide. So what I wanted to talk about here are some of the actions that healthcare providers can take to achieve a lot of these goals. So first of all, this slide's just a general reminder that we all have a lot of work to do to prevent COVID-19. Each of us in the healthcare sector and out there in general have a role to play here. But it's particularly vital for healthcare providers to share prevention messages with patients. Sometimes we're very focused on the treatment, but as you all know, a dose of prevention is a pound of cure. This slide's also a reminder that physicians may wish to consider individual patient risk and remind patients who are severely immunocompromised. This is the special group I was speaking about earlier. Remind people who are severely immunocompromised and those at risk for severe COVID-19 infection to really practice prevention measures, such as wearing a mask, maintaining physical distancing, washing hands frequently. And these are the groups, in particular, persons who are either immunosuppressed from an underlying condition, such as inherited immunodeficiency, acquired immunodeficiency, or immunodeficiency related to a medical condition like cancer, leukemias, and lymphomas in particular, but also those people who may be taking medicines that are intended to suppress their immune system, such as persons with an organ transplant who need mycophenolate, for instance, for organ rejection, or persons who have underlying rheumatologic disorders who may be taking rituximab, or people who may be having other conditions where some of these drugs are used. We really want people in this group to consult their clinician even after they're fully vaccinated to decide whether they want to follow our guidelines for fully vaccinated, or whether it may be more cautious until new infections are further down and more people are vaccinated, for them to continue following all of our advice for unvaccinated persons. I'll note that many people who are immunosuppressed following vaccination do develop some measurable response, but others do not. We don't yet know exactly how to know what correlates with protection, what level of antibodies correlates with protection, or if some people who don't develop an antibody response are rather protected. I always think of the example of hepatitis B in the healthcare sector. And if any of you all have worked in the infection control office in a hospital, you'll probably recognize that a good fraction of people get vaccinated with hepatitis B vaccine, full series, and still never develop the antibody response we want. But we have plenty of data that those people aren't getting hepatitis B. Now, we don't know that that's true. I just want to be cautious. We don't know that that's true for COVID, but as a principle, we don't yet know that the absence of antibodies really, what that means in terms of risk. So we're trying to figure that out. So in that case, I think I might be a little cautious about persons who are immunosuppressed from following our fully vaccinated guidance. And as always, even though things are looking better and better right now, be vigilant for signs of disease if you have underlying medical conditions, and have a short fuse to seek care. Next slide, please. All right, this is just a couple of, at least one slide, maybe more, on additional resources. Actually, let's end at this one, and then we'll take some questions. So this is the last slide. I think these slides will be publicly available, so if you can't write quickly or copy this down, these are just some web pages that we thought could be useful, both for the general public as well as clinicians, related to risk associated with underlying medical conditions. They provide these links, and I hope that you will take advantage of these and use them. Lastly, just to remind everyone, if you have any questions after today's webinar or need to seek some form of consultations, 1-800-CDC-INFO, I think that number appeared on a previous slide, is a number you can call, and we will try to have the operators there refer you for the proper person to consult with. So Commander Khan, I think I'll stop there, and let's take some questions.
Thank you, Dr. Brooks. We will go into our Q&A session now, and these slides are available on emergency.cdc.gov/COCA, so you can find these resources that Dr. Brooks referenced here for you. So our first question asks, have you found underlying conditions that are a risk factor for severe COVID to also correlate with long COVID?
Wow, I love it. That's a great question. It's hard to, I'm not aware, and so my colleagues Sapna and Kanta may know also, but I'm not aware of any particular underlying medical condition that increases the risk for post-COVID conditions, particularly that condition called long COVID, the terrible fatigue, headaches, confusion that really go, and and certainly plenty of other problems, but that go on for months after a person's recovered from COVID. However, what I do know is that there is a general correlation between the severity of illness that a person experiences when they have COVID and the risk for long COVID. And so in that respect, the fact that people with underlying medical conditions are generally at risk for more severe disease, then in that way, they may be at greater risk for long COVID.
And and just to add to that, Dr. Brooks, thank you. I agree. This is Sapna, sorry. There are a number of different ways in which this question is being looked at. So I do think that eventually we will have more information. At this time, we don't have data to directly look at it, but the indirect link that you mentioned, Dr. Brooks, is I think very relevant. But some of those studies look at the natural history of COVID itself, and then others are looking at kind of more of a registry approach at those that do experience long COVID, and then able to eventually look at that data to ascertain if there's any correlation or association.
Thank you very much. I appreciate that. And for our audience, please stay tuned because we are having a COCA Call next week titled Evaluating and Caring for Patients with Post-COVID Conditions. So that would also be very informative. Next question asks, is uncontrolled diabetes worse than a diabetic who is in fact managing their diabetes and other related risk factors well?
So this is John. I can start to answer that. I mean, certainly in terms of their diabetes control, it's worse. I mean, we want people to make sure that their underlying medical condition is controlled in the first place because it's just unhealthy for them and already poses a challenge to their good health, even in the absence of COVID. But as was shown earlier, I think Kanta had the slide. I can't recall, Kanta, if that was just, if it was diabetes or the example, I don't have it right in front of me. But in general, the principle is that the more severe the underlying, if there's a single medical condition, let me put it this way, for a single underlying medical condition, the more severe that condition is across the spectrum of its severity, the greater the risk is for the person to have severe COVID. So, for example, with asthma, you know, there's a whole range of asthma from people who are very mild to very severe. There's some evidence there that the more severe can be a little bit greater risk. Similarly with cardiovascular disease. And I believe the same is true for diabetes, but let me check in with my other colleagues here.
Sure. Thank you, John. This is Kanta. Yes, so that's the study I shared looked at hemoglobin A1C and cutoffs and showed those who have a higher hemoglobin A1C had a higher adjusted hazard ratio. And we've seen this across other studies also. So yes, for patients with diabetes, it does look like those who have uncontrolled diabetes will have, there is a stronger association with severe outcomes. Over.
Great, thank you so much. Our next question asks, and I'm assuming this is talking about individuals that are vaccinated. Should people with underlying conditions have different precautions when it comes to masking?
Right. So certainly for the group of persons who have let me back up. When we talk about fully vaccinated people, we're talking about a suite of interventions that they may now begin to reduce. The first one people think of tends to be masking because it's been probably the one that's been most in the public mind for quite some time, and the one that people are often the most grateful to no longer have to follow. But it does also include social distancing or physical distancing and avoiding crowds and some of these other measures. But that said, speaking specifically about masking as one of these prevention measures, for many people with underlying medical conditions, there isn't really any reason to believe that after vaccination, the quality of their immune response to the vaccine and the extent to which they're protected will differ from anybody else. The exception to that rule, and that really is what would drive the decision around reducing prevention measures. The exception to that rule are, as I described earlier, persons who are immunosuppressed or compromised due to underlying illness or a medical treatment. And those are persons who absolutely should think twice, talk to their provider, and make a carefully informed decision as to whether they really want to wait before they take that mask off.
Great, thank you very much. Next question. Some variants are deemed to be more transmissible or infectious. Is there more severity to them when it comes to patients that may have underlying conditions?
That's a great question. I think that's a concern everybody has, right? When viruses mutate, the way they can do us harm is really kind of in two flavors. They either can be more transmissible, so they move through the population more quickly and more of us get infected, or they can be more severe. and make us sicker. And of course, that's not generally in the virus's best interest evolutionarily, because they don't want to get rid of the host too quickly. But they can sometimes evolve. So it's not natural. We don't expect viruses to evolve to be more severe. That tends to be more of a, or can be a sort of more of a spontaneous event. So what we've seen is for most of the variants, they do not appear to be more severe in people without underlying medical conditions. And in that respect, we don't expect that they would be any more severe in people with underlying medical conditions than the same risk for severity as you would have if it were the old virus that was circulating, or what sometimes is called the wild type. Some people have heard that one of the variants in particular, B117, the variant first described in the United Kingdom, that it is has been seen to be associated with more severe disease. But the association there is very interesting. It isn't that it's making people sicker, but rather it's making more people sick enough that they have to go to the hospital. It's more transmissible as well. And what we're finding, at least the studies from England, which have had enough time to really examine this question, is that more people with the infection are being admitted to the hospital. But once you get into the medical system, survival is the same. So in that respect, it isn't more virulent. It's really what we think is probably going on is the greater transmissibility is driving to larger numbers of persons requiring hospital-based care. In that sense, there's more severe disease.
Great, thank you so much. And I think we have time for one last question. And the question asks, when discussing strategies, as you did, Dr. Brooks, can you speak about strategies for underlying conditions that may be beyond medical management, just based on the nature of the condition itself? What are some strategies that are effective?
Yeah, so it's difficult, isn't it, to to have to work with, not have to, but to have the privilege really of working with people who it's not easy to manage because they've got things that are hard to take care of. And I think in these sort of circumstances, it's focusing on what we know you can do to improve symptomatic care and quality of life. I'm saying this with the understanding that for those conditions which confer increased risk for COVID, that you've got to also, increased risk for severe disease, for those conditions that may be associated with more severe disease and increased risk of death, you need to do as much as you can to just prevent getting COVID. And we've talked a lot about that. Vaccination, of course, is your best first go-to. But I would suggest for persons who are concerned about this, that this advice about not having to wear a mask all the time if you're vaccinated, even if you know or there's no reason why you don't get that full punch from the vaccine, you don't have to take the mask off. You can still social distance. I would recommend people make these changes at a pace that suits their comfort level. We've been through a lot, and some of us have seen some pretty bad things, and this may not be the right time yet for everybody to sort of make that first step, but the time I hope will come. And for people who do have these more difficult conditions that don't have immediate treatment, really focusing energy on symptom management and improving quality of life is a great way to go. Personally, I'm also a very big believer in exploring alternative therapies. There's an institute for this now, the National Institutes of Health. I'm not sure how they work, but I certainly have had plenty of instructive experience with folks saying that worked for me, and finding what works for you is the most important thing.
Dr. Brooks, and John and Commander Khan, I just also wanted to make a couple of comments, if I can, at the end here.
Certainly, please. The floor is yours.
Two things. I think people become very concerned about what's included, or have we thought about all of these? There are lots of conditions. We can only rely on the data that is presented to us or is out there, and I think it's very important to understand that there are conditions for which we may not have a large enough cohort of patients to be able to really look at the data in the same way. Case reports are important. So for those of you providers out there who are seeing patients and noticing things, we encourage you to try and get things in the literature, because it is important to share this experience. But also just to say that we are trying to, institute a process that will start to look at these rarer conditions. I also want to kind of put a plug in for our medical society partners. They have done a tremendous job in their areas of expertise in trying to look at some of these conditions that may, again, not have a large enough cohort to end up, publishing studies, or no one's publishing studies on these individual patients with these individual conditions. And so there is guidance that I think can be brought to bear from our medical society groups that we are all trying to work very closely with. So, we encourage questions through CDC info. Please know we are attempting to look at rarer conditions, and that we still have a lot to learn about associations with severe outcomes.
Great.
I don't know if
Thank
John
you.
or Kanta want to add anything else to that.
I just thank you for that. That's terrific. Thank you very much, Sapna. Yeah, that's very important.
Yep, thank you, Sapna.
Great. Thank you so much. I would like to thank everyone for joining us today, with a special thanks to our presenters, Dr. Sapna Bamra Morris, Dr. Kanta Sarkar, and Dr. John Brooks. All continuing education for COCA calls are issued online through the CDC Training and Continuing Education Online System at https://tceols.cdc.gov. Again, that web link can be found on our slides, which are on emergency.cdc.gov/COCA. Those who participate in today's COCA call and wish to receive continuing education, please complete the online evaluation by June 28, 2021 with the course code WC2922-052721. The access code is COCA 052721. Those who will participate in the on-demand activity and wish to receive continuing education should complete the online evaluation between June 29, 2021 and June 29, 2023, and use course code WD2922-052721. The access code again is COCA 052721. Continuing education certificates can be printed immediately upon completion of your online evaluation. A cumulative transcript of all CDC ATSDR continuing education obtained through the CDC Training and Continuing Education Online System will be maintained for each user. Today's COCA call will be available to view on demand a few hours after the live call. You can find the video recording of today's call at emergency.cdc.gov/COCA. You can find all the links and the resources we shared today at that same link, emergency.cdc.gov/COCA. Like I mentioned earlier, join us for our next upcoming COCA call, where free continuing education will be provided. Our next scheduled COCA call, Evaluating and Caring for Patients with Post-COVID Conditions, will be held 1 week from today on Thursday, June 3rd. This COCA call will be at 2 p.m. Eastern Time. More information and call announcements will be available soon, and you can find more information on emergency.cdc.gov/COCA. Please share the call announcements with your clinical colleagues. Also, remember to sign up to receive weekly COVID-19 science updates by visiting the web link provided here. COCA call announcements for upcoming COCA calls and other COCA products are sent via email. In addition to visiting our webpage, please remember to subscribe to COCA to receive notifications about upcoming COCA calls or other COCA products and services. Be sure to subscribe to receive notifications by going to emergency.cdc.gov/COCA. We invite you to join the COCA mailing list by visiting the COCA webpage at emergency.cdc.gov/COCA, clicking on Get Email Updates and entering your email address where indicated. Finally, to stay connected to the latest news from COCA, be sure to like and follow us on Facebook at facebook.com/CDC Clinician Outreach and Communication Activity. Again, thank you for joining us for today's COCA Call and have a great day.